Welcome to the Neurology Nuts and Bolts podcast, all about constructing your career in neurology. I'm your host, Sarah Schaefer from the Yale School of Medicine, and today, as part of the Types of Careers series, we will be speaking with Hope O'Brien, founder and CEO of Headache Center of Hope in Cincinnati, Ohio, and Diana Bloom, founder of Peninsula Private Neurology in Menlo Park, California. Thank you for joining us today, Hope and Diana.
Thank you.
Thank you so much. It's wonderful to be here.
So Diana, I wanted to start with you. Can you explain what actually is concierge medicine?
Concierge medicine is a type of, in my opinion, billing model where you are billing somebody on a monthly basis and you're delivering a quality care based on that monthly service. However, it's an old label, shall I say, to this billing model because it really is much more than, you pay a monthly service and you get a certain level of care. The newer way of thinking about concierge medicine is direct care. And that's really the new name that we're hoping more and more physicians start adopting. It's really getting rid of all the third parties in between the doctor and the patient and really bringing it back to, the doctor-patient relationship. So getting rid of insurance, basically. So patients come in, they have a direct relationship with their physician. All of the billing is a private contract between the doctor and the patient. And obviously, if the patient has insurance and wants to submit it for reimbursement, we give them a receipt and they can submit whatever their plan will cover. But the idea is that you're getting rid of third-party interference. So when you're making medical decisions, there's not someone else kind of dictating how that works.
So basically, there is a set fee for that's billed on a monthly basis or something like that, and if the insurance companies become involved at all, they become involved on the back end after the fact at the behest of the patient and not at the behest of the provider.
Exactly. There used to be a fee-for-service model where that's more of a traditional, here's what I charge for a 1-hour consultation. And that too, in private practice, you can choose to take insurance or not take insurance. But the fee-for-service model is kind of the, typical what you would see generating RVUs in an employed setting. This is different in that everything that is needed for that patient, whether it's phone calls, refills, video, telehealth, office visits, everything is included in that monthly fee. So patients don't feel like, oh, I can't really call and ask a question because they're going to charge me for that. Or, patients know what they're getting into, so they know that there's no surprise bills, there's no surprise anything. They pay their monthly fee and they have full access to, whatever their medical needs are.
Okay, so that direct patient care label has to do with cutting out the middleman, cutting out that obstructive insurance that's getting in the way of the indirect patient care.
Exactly.
Hope, do you have anything to add to that?
The way I like to look at it is this kind of a model is very transparent. So patient knows exactly what they're getting based on the price that they're paying either per month or per year. My model is a little different in that I do have a fee for service, meaning if patients want an initial consultation, they pay a upfront cost for either a 60-minute or 90-minute consultation. 60 minutes for new visit, and they haven't seen any other neurologist or headache specialist. 90 minutes if it's a second opinion consultation. And then if they decide to, let's say, continue under my care, then they can opt for a membership model. And that's where they actually pay an upfront fee at either the first visit or during a follow-up visit. And so that actually covers them throughout an entire year. Patients would then sign a contract saying that they would be getting these kinds of services for the full year. And then that way they have the freedom to be able to have these services as well as have direct access via my phone, my personal cell phone, should they need it.
Let's dive into the history a little bit more before we go into more details about your individual practices. How did concierge medicine originate, and why do you think it's gained steam in the US in recent years? Hope?
I will tell you, this direct care model is becoming more and more popular for, I think, several reasons. Number one, providers are finding that they need more time to spend with their patients. And, there was a lot of frustration under an employed position where there was a lot of emphasis on RVUs and seeing as many patients as possible, less time, but then you are, expected to provide the same quality of care. And so really primary care physicians were the ones who really started this type of a practice because they felt that a lot of these patients were chronic and they needed services throughout the year. And so if they could get a population of patients who are willing to spend, the money for care of their chronic illness, they can afford time with those patients and be able to really care for them without the burden of an employed position. And I think for a lot of subspecialties, especially in headache, it's becoming more and more popular. And I think patients are also finding it a value because they're also able to spend the time that they need and get direct access to their providers when they need it.
Great. Diana, would you mind telling me about your particular practice?
Sure. And I'll piggyback just on one thing is I think it's the corporatization of healthcare that is driving now the direct specialty care movement, shall we say. So physicians feel like, they want to get back into really practicing our art and our trade. And, it's hard to do that when someone is telling you when to see your patients and for how long. So my practice is focused actually on the chronic management of Parkinson's disease. And I 100% agree with Hope that probably it's the chronic management of chronic disease that is best suited for this. And Parkinson's is obviously a perfect example. I would say MS is probably a great other neurological condition that patients would serve probably better with more hands-on care. So in Parkinson's, I see my patients every 6 weeks. There's so many non-motor symptoms that often patients are more debilitated with than their motor symptoms. And it's just so hard when you see your patients once every 3-4 months or once every 6 months to be able to really address a lot of those non-motor symptoms. I would actually argue the motor symptoms are the easier things to manage with this disease. So that's basically what I do is, my initial consultations are usually a 4 to 5 hour visit where a lot of education is involved and we're setting up kind of the big picture of how we're going to manage it. And then after that, it's, patients come in every 6 weeks. Those are usually 1 hour appointments. And obviously, if there's issues in between, I'm available via phone or email. And, things do come up, but usually when you spend that full hour every 6 weeks with a patient, you'd be surprised. They really, most of the issues are addressed and they know how to handle it. And there's not anything that really comes up unless it's truly an emergency. And then you're glad the patients have your phone number or email to get a hold of you.
And Diana, are you in some kind of a group? If a patient with Parkinson's, I also am a movement disorder specialist and see Parkinson's patients. And sometimes they also have headaches, or they have fasciculations that you notice on exam and they need to be seen by a neuromuscular specialist. How do you deal with those types of situations?
Before I started focusing on Parkinson's, I was a general neurologist for gosh, 5 or 6 years. So if it's something straightforward like a migraine or, neuropathy, I manage it myself. I am technically in solo practice, so I have no other partners, but I share an office with a neuromuscular neurologist who has his own completely separate practice. But if I ever needed, that form of, get an EMG or something like that, it's easily available here. If I need something, much bigger, like if, DBS for a patient, then the closest hospital to me is Stanford, and that's usually where I refer.
And Hope, how is your practice set up? I just want to put in a little plug here for the using your dual degree MD MBA episode that we did with Dr. O'Brien as well as Dr. Paul Fu. So I know about the nascence of your practice after you got your MBA, but tell me how it's set up from the perspective of direct patient care.
I did go back to school and get my executive MBA degree. And really, I wanted to be able to learn and be more comfortable with the financial aspects of medicine. And I just felt like we didn't get enough of that in medical school. And I knew I wanted to ultimately start my own practice and wanted to really get into the details of the business side of things. And so I started my practice. I opened in June of 2021, and it's a solo practice. I have a registered nurse who works with me, as well as a practice manager, and then I have an assistant. I have an office space in a building that I ended up purchasing, and patients come in for an initial evaluation. And as I mentioned before, they spend either an hour or 90 minutes, and what they pay initially will then cover a follow-up visit. Patients can choose to follow up and pay an a la carte price for that, or they can sign up for membership. And those who have signed up for membership, I have 4 members since we've opened. And those who have signed up for membership are those individuals who've been dealing with chronic migraine or chronic headaches for a long time and really want that personalized approach. When I developed this concept of providing this specialty care for patients with headache and migraine, as I put my business hat on, I was asking the questions, what didn't exist out there in terms of headache care? And we know that headache and migraine is so common. And when you have a migraine attack or a severe headache attack, you don't predict those. And a lot of these patients end up in the emergency room, or they may end up in the primary care doctor's office. And oftentimes, unfortunately, with the way, the corporate system is set up, they spend, primary care doctor doesn't have a lot of time to spend with these patients, or they may end up at a facility, getting a massage or, a chiropractor or any other type of allied care, not really addressing the migraine issue. And so I opened up my practice that caters towards these individuals. It's a very spa-like environment. It's very soothing. The lights are dimmable. It's very quiet. It's a one-stop shop for patients. So instead of going to the emergency room, they can come right in and get treatment right in the comfort of their own private suite. They see a board-certified neurologist and headache specialist, and they leave empowered, knowing that they, first of all, were treated adequately and appropriately, and they know what to do in the future should they have a migraine attack. Because of this model, I'm able to get patients in pretty quickly. That was the other value proposition. So patients are able to be seen within a period, either same day or within 72 hours, which, as you know, for a neurology practice or headache provider, it can take anywhere between 3 to 9 months to see a specialist. So those are the kind of things, that I thought of as, I try to put together this model, what was kind of missing out there and what would patients be willing to pay for this kind of service.
Can you shed some light on how your day-to-day might differ from somebody either in a different private practice model or academics, perhaps in terms of documentation? We're going to get to billing later in the episode, or any other differences.
So the documentation portion of it does not take really any more time than what I spent in when I was working as an employed position. However, now I have the time to do it. That's really the difference. It doesn't take me less time, but I just have the time to do it. But the other thing too is because I've opted out of insurance, I don't have to, adhere to all these checklists of, we've got these, practice measures that you've got to check that really at times can be irrelevant in neurology. And so I don't really have to focus on that. So for me, it's a lot more streamlined, and I can really develop a note in a practical way that's also helpful for individuals, for the physicians who are referring. I can send them back my note, and it's pretty detailed, and they love it.
Diana, do you feel like there are ways that your day-to-day is different?
Oh my gosh. So first of all, I work part-time. I'm a full-time mom. And so the flexibility of being able to make my own schedule, congratulations for making the plunge, right? Because I think this is the future. I actually started my practice in November of 2013. So my practice has been closed to new patients since 2016 or 17. So my point is you're going to get, I think, really busy very quickly. And then you're going to have to decide for yourself at what point you have enough patients where, you don't want to dilute the quality of your care, right? So that's kind of where I was back in 2016. And that's when I decided, you know what, the patient population that I think I can do the most benefit for and really dive deeper and deeper in was Parkinson's. So I say that because my day-to-day back then was a little different than my day-to-day today. So today, a lot depends on if I'm seeing a new patient, because if I'm seeing a new patient, that's the only patient I see that day. As I mentioned, it's a 4 to 5 hour visit, and that's all I do. If I'm seeing follow-ups, a typical day for me, because I'm part-time, is 2 to 3 hours, 2 to 3 patients a day. And then that frees up to actually do some deep dives into either research, or I do a lot of physician advocacy work. So it's nothing like the employed setting where, you're every 15 minutes in and out of a room. And then, at the end of the day, you've got, 3 hours worth of charting to do. My charts are closed by the time I leave the office. From a work-life standpoint, it's given me sanity. And it also was at a time where, I will admit I was completely burnt out and even contemplating leaving medicine. So this was a refreshing way to be able to stay and actually thrive and give my patients what they need. So the day-to-day is easy. I don't have any real staff. I have one office manager who kind of does everything for me, and she's part-time too. I do my own orthostats and vitals. I, room my own patients. It's a family kind of ordeal. I love it.
Yeah, I was just going to say, Dan, my day is very similar to that too. I agree. I think at the most I see in a day is 3 patients in a day at the most, which is lovely. And, to break even, you really don't need to see that many patients because, again, you're using a cash-based model. It's fabulous.
And you get rid of all that overhead. I too am opted out of Medicare. I'm not contracted with any insurance. There's no billing. I don't need to hire a biller, right?
Mm-hmm.
So everything is kind of direct to me and my patient. If there's a problem, or if, with the pandemic, here's an example of how being your own boss, you can really make a difference. I have some patients where they went through a rough patch. They lost their jobs. They couldn't afford it. I said, it's okay. I'm going to keep taking care of you because that's what I do. And when you get a job and get back on your feet and, and if that doesn't happen, we'll figure it out. And, there are a few people I continue taking care of for free because, I want to and I have that ability to do that.
Right.
So yes, I think it's just bringing us back to truly Hippocratic Oath medicine.
Mm-hmm, mm-hmm.
Tell me a little bit more about billing, and I'm also very interested to know how studies like MRIs, stat scans, and prescribing medications works. You've both mentioned that you've opted out of insurance. What exactly does that mean, and how does billing work?
So what that means, by opting out, you don't accept insurance. So in other words, you don't submit any of your chart or billing to any insurance companies, and you don't get reimbursed by any insurance companies. So in order for patients, if they want to go through their insurance, they would have to submit a super bill. So I do provide them with a diagnosis code, and they can then, and then the time, how long I've spent with them, and then they can submit that to the insurance company for reimbursement. But it's really direct pay. The patient pays me before being seen. In terms of workup, whether it's labs or imaging, they do need insurance to get those. It's the same thing with the pharmacy. So they can submit for pharmacy if they don't have pharmacy benefits, but if they do have pharmacy benefits, I can write a prescription and it goes to their pharmacy benefits. Same thing with imaging. I'll write a prescription or order for imaging, and then they take that to wherever they'd like the imaging performed. Same thing with labs. I mean, you can just write an order and they can take their lab order to whatever lab site, as long as it's signed by a licensed physician.
And so if any of these medications or imaging requires prior authorization from insurance, is that something that you perform?
Correct. So part of the fee includes the time spent doing prior authorizations.
Okay. Diana, do you have anything to add?
Yeah, so because as you can imagine, most Parkinson's patients are Medicare, and I've opted out of Medicare, they actually have to sign a separate contract saying they're not going to try and bill Medicare for my services, because that would be, illegal for both of us. Mm-hmm. So the Medicare patients really don't have a way of getting reimbursed. I think that does limit, unfortunately, some of the Medicare patients' ability to use this type of service if they're on a fixed income, and that is unfortunate. And I hope part of some of the advocacy work I'm working on is trying to fix that issue. If they're non-Medicare, it's the same thing. If they have an HMO, they know I'm considered out of network and they're not going to get reimbursed. But certainly if they're got a PPO, then whatever the out-of-network coverage is, I would give them a super bill and they get reimbursed for the time that I spent just in the office visits. I there's no billing codes for all the other stuff we do. And my part-time office manager, that's literally her job, is doing prior auths. So if I order, that's literally all she does. If a patient needs a Botox for their dystonia or something, we get everything approved, and there's no surprise bills when they come.
Where did you first learn about concierge medicine or direct patient care medicine, and what made you interested in using this model, Diana?
I think it was realizing that I wasn't sleeping at night because I was not feeling like I was addressing half the issues, and then being on call covering, many other doctors where I felt like I wasn't doing that adequately because I was looking at, notes that were basically copy and pasted from 3 months ago, so it was just getting a sense of, this is not what I signed up for. So I actually started cold calling concierge primary care doctors in my area, and came across one who just happened to love what he did and just told me all about kind of his journey. And I'm like, that, and obviously where he ended up, which is being able to sleep at night and take good care of his patients and, all of that. And I'm like, that's what I want. So I was really just motivated by feeling like this, I did not sign up for what I was doing. And this was kind of my way of able to still practice medicine, but, sleep at night.
And what about you, Hope? Where did this idea come to fruition?
So, similar to Diana, I was in this academic practice and I enjoyed what I was doing, but what I didn't enjoy was the loss of autonomy. Medicine started to become more and more of a business, and I just was losing myself because I felt like I wasn't practicing the way I had envisioned practicing. I wasn't spending the time that I wanted to spend with my patients. So I was honestly just talking with some colleagues, and one of them had left academic practice and had started her own practice, and she was in primary care, and she had done well to the point where she ended up going back into academic practice because this organization bought her practice. It was a cash only practice. And so she was brought back onto academics to help run a women's center. And over time, she got caught back into the same old with RVU production and not spending enough time with her patients and not having that autonomy. So then she went back out into private practice and started this direct primary care model, a monthly cost to patients, and was able to break even and do well in such a short amount of time. And within 3 years was able to franchise. So she was able to grow other direct primary care offices around the country. So that intrigued me. And when I was in my MBA class and looked at this and thought, could this be done for, the type of patients that I was taking care of? During my market research, the answer was a resounding yes. And so that's how I got introduced.
This has been so interesting because both of you have touched on work-life balance and burnout and quality of life and how that has all been improved in the setting of shifting to this model of practice. And one conception, it sounds like misconception that I had going into this interview and that other physicians may have is that because the patients have access to you at all times, they have your cell phone numbers, your email addresses, that may poorly impact work-life balance. What are your thoughts on that? And related question, what do you do when you go on vacation?
So I will say, of course, I deal with headache and chronic pain patients. And so that was definitely an initial concern. And so I thought, okay, well, let's try this. And I will tell you, the patients who I thought were going to be the ones calling all the time, they don't call. Because as Diana mentioned, you're spending so much time with them so that by the time they leave, and they leave with like a plan, like they actually have a packet that they leave with that goes over everything we talked about and the plan, they don't call. I mean, to the point where I will actually check in with them and I'm like, do you need a follow-up? I mean, I haven't seen you in a while. They don't call. So it's really been, I've had a few patients who checked in, after an initial visit just to clarify things, but it has really been absolutely wonderful. And, I do give patients a contract and that, this is a mutual relationship. I give them a money back guarantee. So in 30 days, if this is not something for them, I do refund them a portion of their money that they, except for the initial visit. And so it really needs to be a mutual understanding. And, you can choose to make these patients a member or not. So I honestly, it's been wonderful. I've had no complaints. And then when I am out of the office, I do have in the contract that I am allotted so many days off on vacation. And so I let them know I'm going to be out of pocket. If there's an emergency, this is what you do. I am going to be working with a colleague of mine who's doing something similar, and we'll work on coverage that way. But so far, for the last 10 months, it's really not been an issue.
Yeah, same. I have to say, so since 2013, I have taken international vacations with the family. As much as even being gone for a whole month, I just made sure to see just about everybody right before I left. And because it's, every 6 weeks that I see most people, then I really bought myself a good 4 weeks to be able to, go travel. And I'm the amazing thing about 2020 or the 2000s is the technology, right? So I am still a phone call or an email away, and they know that, and that is their peace of mind. And of all the trips I've ever taken, have I gotten a call? I think of the 7 years or whatnot, maybe 2, and they were really important that they did call me. But my point is that patients value our time. I think that that's something very rare to hear these days. But like when you give compassionate, good medical care, you're going to get that, oh my God, thank you, doctor, back. And it's so rewarding. So, and in those two instances, yes, I made sure that there was a local neurologist that was, available in case there is that rare person that needs to be seen. And that's what I did. I called that person. But again, it's so rare that, especially with Parkinson's, there's truly a Parkinson's emergency. So I'm a little bit protected that way. I think if I had a stroke practice, obviously that would be a different situation.
I'm wondering about the patient population in your practices. We've mentioned that patients who are on a fixed income or on Medicare or Medicaid may not have access to this type of care because of the out-of-pocket expense. Or if they have poor health literacy, they may not be able to bring their information to insurance companies to request reimbursement if they're allowed to. So I wonder how your patient population, how you feel it differs from the types of patients that you were seeing in other types of practice in terms of their health literacy, their wealth, their diversity. And Diana, if you want to talk at all about any of the advocacy that you also alluded to, that would be great.
In terms of if a patient is uninsured, it's probably the best type of way of delivering neurological care because patients know exactly what they're getting into. There's no surprise bills, there's no facility fees and, exorbitant charges. So I actually do have patients who are uninsured and they can commit to their monthly fee and that's it. I have other patients where it is an issue because they have insurance and they're paying for insurance or their employers are paying for their insurance, but they still prefer this because they have a high deductible plan. And for them to go see, again, in a facility, even if they're in network, if they have a $15,000 high deductible plan, like it's still cheaper to pay out of pocket the monthly fee for me than to go through their insurance. So for those patients, it makes more sense. For the Medicare patients who again are on a more fixed income, that's the patient population I feel isn't being served at the moment. And some of the advocacy work I'm hoping down the road we're going to see is that patients actually who are eligible for Medicare can choose to do like a health savings account instead. So whatever Medicare would be paying for them in a per annual, year, they can actually put it in some pocket and use that for however, they want to spend that pot of money.
Yeah, I would agree with Diana. What I do is we'll do a 30-minute initial consultation with anyone, whether you have insurance, don't have insurance, and really it's an opportunity for them to meet me, for me to meet them, and to see whether or not this is something that they're willing to try. And then if they decide that it's something that they aren't able to do, I do give them a list of my colleagues who specialize in what I specialize, so that at least I can direct them to the right or appropriate individuals that do take insurance. But I would agree with Diana. Oftentimes, a lot of these patients will have either they don't have insurance or they have very, very high deductibles. And I've had patients who've actually moved from an insured place to my spot because my costs are so much lower. So in order to get an IV treatment, oftentimes their deductibles are so high, and to get IV therapy is much less than what they charge at a lot of institutions. So I always tell patients, I give them the price list. They can look at that. They can see what they've paid in the past or what the cost is, even with insurance. And then they make the decision of what makes sense. The patient population that I'm seeing, I really can't say that it's, those that are the upper income. I really have seen the broad spectrum. Those who are of lower socioeconomic status, and then in between, and then higher income. I was surprised. I thought I would see, a certain socioeconomic bracket, but I'm really seeing a spread of individuals.
Wow, those are surprising answers.
Mm-hmm.
Yep. I mean, I have patients who qualify for, patient assistance programs for their medications because they can afford me, but not their medicines. I mean, that's the unfortunate reality in, today's world.
Well, this has been very eye-opening. Before we end, any other misconceptions that you want to clear up or tips that you have for anybody who might be interested in this particular path?
No, I would just encourage, folks who are in training right now to really research their options. I think it really is important to understand that there's really a lot of different ways physicians can take the autonomy back and, be rewarded from good patient, encounters that really make life meaningful again. And I say this because I know we're in the midst of a major burnout epidemic. And I don't call it burnout anymore. I call it moral injury. I think
like
our
that.
system is abusing our goodwill, our love of people. And this is one way for us to take control back.
Absolutely. I would agree with Diana. I would say that, first of all, this is the best decision I've ever made. I will never go back. It's awesome. I mean, the love of medicine is back. I love taking care of my patients. I have the option, I thought, oh, well, it's either academics or private practice. And, the private practice is no, not the way to go. And I'm able to enjoy both. You can have it all. I'm still involved in academics. I'm still very much involved in research. I'm starting up some clinical trials. And so it really is the best of both worlds. And so I agree. I would encourage anybody in training to really, think outside the box, think about what they want. And because it is possible to really take ownership and take back control of your life and your work-life balance.
I would say look up Free to Care. That organization has a lot of resources, and it's basically a coalition of many other organizations that are really thriving to make this more accessible to more patients and more physicians in all different specialties. So there's like a direct specialty alliance that a friend of mine who's a rheumatologist started. You can imagine any specialty that has chronic conditions that need chronic management, those are suited for this type of model. Honestly, reach out to, I'm happy to answer any questions if you're thinking about making the plunge and just don't know where to start. I am truly here to help. So
don't let fear of the unknown keep you from the possibilities of, the best life you could live in your career. I think when I talk to other providers or neurologists, I think they're like, well, they're not business people, and you don't need to get an MBA in order to start your practice. You don't even need to know a lot about business to start your practice. There are specialists out there. I'm happy to talk to anybody, or, I'm happy to share my email so you can reach out to me with questions. But, my goal is to try to help encourage more and more neurologists, because I agree. I think, there are issues where neurologists are not happy. And so there are alternatives in order to live a life that you're happy with.
Well, this is one of the main objectives of this podcast in general, is to show all the possibilities. So thank you for enlightening us about this particular one.
Thank you. Thank you.
Thank you so much, Sarah, for having us.
Neurology Nuts and Bolts podcast was created and produced by myself, Sarah Schaefer. This podcast is not recorded as an official podcast of any institution or organization. The podcast is unfunded. Opinions are those of the individual participants. Music by Audrey Nath, artwork by Shivani Ghoshal. Want more content like this? Be sure to subscribe to the Neurology Nuts and Bolts podcast wherever you get your podcasts. To hear more about constructing your career in neurology, follow us on Twitter at NeuroBolts and on Facebook at Neurology Nuts and Bolts to stay up to date on new content and give us feedback on what you want to hear, and tell your friends. Thanks for joining us.